Right. Welcome everyone. I think folks are still sort of piling in, but let's go ahead and get started. I'm Brandon Nokes. I'm an assistant professor at UCSD, and I direct the hypoglossal nerve stimulation program at VA San Diego. Today, as part of the SRN Assembly Journal Club, we're going to talk about the Surmount-OSA trial. And we also have special guests, so Atul Malhotra, who is the global PI for Surmount-OSA. And is a world expert in sleep apnea pathogenesis. And then Brian Wojeck over at Yale, who's a assistant professor in the Division of Endocrinology, Obesity Medicine, and Sleep Medicine. By way of disclosures, so no relevant disclosures for me, but I am funded by a VA CDA2 award as well as an NIH loan repayment program. Dr. Malhotra has funding from consulting fees from Eli Lilly, Livanova, Sol, Powell Mansfeld, and then ResMed has provided philanthropic donations to UCSD. He's also funded by the NIH. Dr. Wojeck has no disclosures. And our objectives today will be sort of threefold. So one, I'll start with an overview of obesity and OSA. Two, I'll dive into the Surmount-OSA study. But then for the latter half of this, I'll open it up for discussion and questions with Dr. Malhotra and Dr. Wojeck. So as of 2019, it was estimated that nearly 1 billion individuals globally have obstructive sleep apnea, and that number is thought to, likely increase over time. Likewise, obesity affects over 600 million globally, adults, as well as 100 million children, and is anticipated to impact up to 1 in 2 adults by 2030. Obesity is a known modifiable risk factor contributing to OSA and may be attributable to up to half or even more of OSA pathogenesis through multiple mechanisms. Our group and others have looked at how these two diseases interface. Rich Schwab and his group have shown that tongue fat change, as well as peripheral fat pad changes with BMI, and are likely attributable to behaviors in terms of upper airway collapse. Likewise, with weight loss by surgery or medical weight loss, tongue fat changes also correspond to AHI improvements. So Chris Schmickel locally has a pretty large clinical cohort that he's endotyped, and he calls the snooze cohort. So we had a paper earlier this year looking at sex differences and how it is that BMI influences the AHI by way of the endotypic traits. And this was in over 2,000 individuals. We looked at men versus women, and you can see these diagrams showing, so BMI on the left-hand side, endotype traits, and these are sort of composite endotype traits, like upper airway stiffness is a composite of V min and V passive, which I'll sort of talk about. And then how do these things influence the AHI? And there are differences in men versus women. Men tend to have AHI changes in relation to upper airway collapsibility, whereas with women, much more of the AHI change was in relation to changes in circulatory delay. And the thought behind that is that as BMI goes up, body surface area goes up, cardiac output goes up, and event duration goes down. So if you're scoring the AHI, you have these very short event durations that can really increase the AHI. Also worth acknowledging that with women, there are differences between pre and postmenopausal women with respect to these relationships. So prior work with Scotty Sands and Atul and others have shown that if you look at individuals who have a BMI greater than 25, so overweight and class 1 obesity, and for the groups they're comparing, the median BMI was around 31 for this particular study. But they wanted to assess, well, in those who are overweight, who don't develop sleep apnea, what drives that? And it turned out there were differences in upper airway gain or upper airway responsiveness to ventilatory disturbances. So if you get flow limitation, your response to that or your ability to buy back ventilation is increased in overweight and class 1 obese individuals, who don't develop OSA. We followed up on this in class 2 and class 3 obesity, and I'll give you sort of a rundown of the traits that we were examining here. So in red is OSA, blue is non-OSA, and this is a prospective study of individuals within the bariatric clinic here at UCSD. And this first box you see is VMIN, which is ventilation at native ventilatory drive. So it's thought to be the best sort of modern surrogate of peak RIT. And individuals with OSA have a lower VMIN, or i.e. a more collapsible upper airway. There were modest differences in V active, which is ventilation at close to the arousal threshold. V comp is a sort of composite metric comparing V active to V passive, and not a lot of differences in that composite metric. Loop gain or ventilatory control system stability, not a lot of differences there. And then when we look at the arousal threshold, it was higher in individuals with OSA, which is thought to be sort of an acquired phenomenon as a consequence of having OSA over time. And that'll be in the Annals ATS in November. So in terms of other sort of mechanistic relationships, so Vishnavi Kundal has some cool work showing that individuals with obesity and OSA tend to have increased metabolic activity in visceral adipose tissue, perhaps explaining some of the clinical consequences of those two diseases interacting. Likewise, Priya Borkar has some great work showing that hypopnea duration can vary across individuals, and in particular, and as part of this paper, individuals with obesity tended to have short event duration, perhaps in part explaining the increase in AHI that you can see with obesity. All right, so now for the, and there's much more work in this field, but just to sort of dive into the study. So Atul and others recently published in New England Journal this Surmount-OSA study, which was tirzepatide for the treatment of obstructive sleep apnea and obesity. Their inclusion criteria were individuals with a BMI greater than 30, adults, and moderate to severe OSA. They excluded diabetics because their weight loss responses are different than non-diabetics. Those with planned OSA surgery, mixed central sleep apnea, as well as significant craniofacial abnormalities. And it's worth noting, so all of their primary and secondary outcomes were pre-specified and cleared with the FDA before proceeding with the trial. The primary endpoint was looking at tirzepatide versus placebo, and reduction in the AHI 4% at 52 weeks. And that's with a 20-week lead-in time to maximum tolerated dose of tirzepatide or placebo. Secondary endpoints was percent reduction in the AHI, percent participants with a greater than 50% reduction in the AHI, percent participants receiving an AHI reduction to less than 5, so curing their sleep apnea, or having mild sleep apnea with an Epworth less than 10. They also looked at the reduction in the sleep apnea specific hypoxic burden, which is associated with cardiovascular outcomes. Additionally, they looked at changes in systolic blood pressure towards the end of the study, and this is prior to the end of the study, they had sort of a CPAP withdrawal part of it, so as not to have an upper airway training effect whenever they looked at their terminal sleep studies. Changes in high sensitivity CRP, which is associated with cardiovascular outcomes in the Jupiter trial and others, and then percent change in body weight at week 52. And then in terms of patient-reported outcomes, they looked at sleep-related impairment with the PROMIS 8A form, as well as sleep disturbance with the PROMIS 8B form. This is a trial design that they thought quite a lot about and published the design in Contemporary Clinical Trials. So they had two sort of parallel trials going on. One are those with, intolerant or refusing of CPAP. receiving either tirzepatide to maximum tolerated dose versus placebo and following out to 52 weeks. The second trial is tirzepatide to maximum tolerated dose or placebo following out to 52 weeks. And you can see here there's the sort of the gradual dose escalation to the maximum tolerated dose, and then having the 52-week follow-up. In terms of the patient characteristics of those who were enrolled in the two studies, so 234 in trial 1 and 235 in trial 2, which is no easy feat given the nature of the study. Age ranges were similar, so 48 to 51 or so, and they did a great job including female participants, and this is an important point that they got roughly 30% females. They didn't want to include more than 70% males. The rationale in part behind that is that a number of obesity studies are predominantly female and a number of OSA studies are predominantly male. So trying to make the findings as generalizable as possible. In terms of race or ethnic groups, it was pretty well distributed. Obviously, two-thirds of the individuals were white, but 40% or so were Hispanic, and 6% were, or 5 to 6% were Black or African American. But worth noting, this is across 9 countries and multiple sites. So the demographics sort of vary depending on where they were pulling from. In terms of the BMI, around 39 starting out. So and that was well matched across all arms of the 2 studies. Yeah, AHI, so fairly severe sleep apnea, around 50 for all groups. And you can see the breakdown here. In terms of the Epworth score, around 10, so sort of modestly sleepy. And then in terms of their sleep apnea specific hypoxic burden, fairly similar between groups. Likewise, starting blood pressure was around 130 for the majority of individuals assessed, but worth noting that 75+% had hypertension on enrollment. And then in terms of their biomarkers and other sort of outcomes they're looking at, there's baseline, pre-diabetes percent, 65%, and their baseline HbA1c was around 5.6. In terms of the primary outcome, you can see that tirzepatide versus placebo, pretty marked reduction in the AHI in both trial 1 and trial 2. In terms of body weight percentage, body weight change from baseline, also fairly marked reduction in both trials, overlapping with the reduction in AHI. In terms of their primary endpoint, so in the tirzepatide group, you had a 25 point reduction in the AHI. In trial 1, 29 in trial 2. In terms of their secondary endpoints, a 50+% reduction in the AHI, with nearly 2/3 receiving greater than a 50% reduction in the AHI. 40% or so having their sleep apnea cured or reduced to mild with an upward less than 10. Obviously, these changes are not paralleled in the placebo arm. 17 to 19% change in body weight, significant reductions in hsCRP, as well as the sleep apnea specific hypoxic burden. They also had fairly marked reduction in systolic blood pressure, between 7.6 and 9.5% in the two trials. Diastolic blood pressure also reduced, although not as much. Pretty impressive findings, and I would say the sort of key summary, from these data are that tirzepatide provided superior and clinically meaningful improvement in OSA severity. They had severe improvement in the cardiovascular risk factors assessed, HSCRP and sleep apnea specific hypoxic burden. Likewise, they had superior and clinically meaningful improvements in patient-reported outcomes of sleep function and quality. So pretty important advancement in our field, and I think with those findings in mind, we're sort of teasing out where to go next and what this means and how do we sort of integrate these changes into our sleep practice. And with that, I'll just open it up for discussion. And in case, for those of y'all that signed on late, we have Atul is here, and then we also, who's the global PI for the study, and then Brian Wojeck, who's obesity, endocrine, and sleep doc over at Yale. Thank you. And Atul and Brian, thanks for coming.
Our pleasure. So are there any questions yet? Because if not, I can I'll just jump in.
I don't see any in the chat. Go for it.
All right. So I thought this study was monumental. We've been waiting for this study, I think in the sleep field and certainly in my field. We've known for a long time that weight has really important effects on obstructive sleep apnea. There was an old study, which was by, one sec, let me pull it up here. But it was by Terry Young and Gottlieb, looking at epidemiology of OSA. And it looked at multiple kind of studies in terms of weight loss and the severity of OSA. And what they kind of found was that a change in BMI of 1 decreased AHI by 6.2. That might be a bit an overestimate, but really an important finding. So this isn't new. But what this study brings to the table is data to show that these weight loss therapies have really important effects on obstructive sleep apnea. Now, I don't think that this will be the solution to fix all the obstructive sleep apnea in the world. All right, the patients that came to this study had on average an AHI in the 50s and had a 50% reduction, which is monumental, right? Without a doubt. But many people will still need to be on CPAP and still need some sort of treatment. But especially as an adjunct therapy, this is really important information and data to help our patients to not only treat sleep apnea, but also other comorbidities associated with obesity. So in my clinic, and I'm kind of a weird guy, so since I do a little bit of everything, I do endocrine, obesity, and sleep. But in our sleep clinics, I will evaluate patients to say, hey, should we start obesity therapies out of sleep clinic? And so we will often start those and get additional support from my other clinics in GI, particularly with nutrition, exercise, and whatnot. So that's kind of my initial thoughts, and I'll open it up. I'll wait for the peanut gallery to pipe up.
Thank you. And I should ask, Atul, are there any key points that I didn't mention that you'd like to bring up?
No, I think you covered it well. A couple points to emphasize, though. The Cherno study was in New England Journal like 10 years ago, looking at either weight loss or CPAP or both. And I think the bottom line most of us believe is that treating both is better than treating either one alone. So for too long, we probably put a Band-Aid over the problem and just gave people CPAP and ignored the underlying cause. And the analogy I use in pulmonary is if you have COPD patients, you give them bronchodilators, you don't address their smoking, that's probably not being a great doctor. So I think nothing's changed in terms of our standard of care. It's still important to treat both sleep apnea and obesity, not either one alone. It's important to emphasize in Surmount-OSA, we didn't have a direct comparison between tirzepatide and CPAP. It was CPAP treated patients got tirzepatide or placebo, and non-CPAP patients got tirzepatide or placebo. There was no comparative effectiveness that one is better than the other or worse. And so we didn't try to change the standard of care. We're trying to, as you said, Brandon, add to it by giving adjunctive therapies. And so we now have a more effective way of addressing obesity than just diet and exercise, which unfortunately many of us struggle with.
And I have to admit, I feel as though the field of obesity medicine has really expanded very rapidly, and there's been this sort of explosion of drugs. And I mean, just for the sake of comfort, I know I'm following and Brian's footsteps and pursuing obesity certification, and Chris Schmickel here is doing that as well, just to have some comfort with adding these meds to the clinic. Are other folks in the audience doing that too?
There's a question in the chat about FDA approval too, which I can address while people are responding to you, Brandon. Somebody's asking about adolescents as well. There's a question about the FDA approval. So what's public knowledge is we submitted on June 21st, the same day we presented the American Diabetes Association. In fact, Vaishnavi's on as well, and she was there for that presentation. So we did submit to the FDA fast track approval for sleep apnea as a treatment for sleep apnea. But it's important to emphasize that when Zepbound was approved about a year ago, that's tirzepatide for obesity. So it is already approved for obesity. So sleep apnea with obesity in theory doesn't change much. But whether payers are paying for it and stuff is a separate discussion. And my guess is if the FDA does approve it and there's non-label indication, then it'll be hard to avoid.
Brandon, I have a question. Thanks for that great presentation. So I guess, moving forward, I'm just curious, you said you guys are already kind of, how do you envision sleep clinics incorporating this therapy into their, kind of treatment regimen that they offer patients? Sleep providers are very multidisciplinary. So, would it make sense for someone to be obesity certified for, you kind of need like a dietitian, and then there's the insurance piece. And then my other question was also, do you think, I mean, this is just speculation, but do you think that given that it is FDA approved for obesity, and if and when it gets FDA approved for sleep apnea, will the coverage be easier with the dual indications? Because right now, a lot of the patients, it's very difficult to get it covered just for obesity.
Yeah, great questions. Thank you. So in terms of the coverage, I imagine it'll be easier just by virtue of the potential downstream effects of preventative care that you'll achieve and potential cost savings from that standpoint. In terms of implementation, I should note that that the venue through which I'm doing this will be at the VA. So within the VA system, at least locally, we have an obesity task force, which is multidisciplinary, has psychiatry, has nutrition, has endocrinology, and so I'm not doing this on my own. There's a team of individuals available to work with me to help provide guidance and the multiple aspects of obesity care that are necessary to achieve good outcomes in this context. And I acknowledge that this will be sort of different across different clinics and whatever's available to you locally. But I can also say that within the UCSD side of things, the obesity clinic is so backlogged that they're no longer accepting new patients. So then the burden, I think, shifts, or not burden, but the onus shifts to primary care, other specialties, and sleep is at the interface of a really important potential for intervention and improving patient outcomes. So I think the sleep clinic is probably a really great place to do this.
So I'll jump in on this too, since I'm prescribing out of sleep clinic. I'll say that I have a lot of support to do this. That we have, a specialty pharmacy that manages this. We have nutritionists in our obesity center. So we have a lot of resources to work with. But I would say that 60% of these medicines right now are being prescribed by primary care, and frankly, that's how it should be. If the obesity is too prevalent a disease for it to be left to just the specialists. So it's a team approach. So certainly sleep doctors, primary care physicians, everyone's kind of in on managing these patients, because obesity is kind of complex and needs many hands to manage. In terms of coverage has been tricky because these medicines are expensive. And insurers have been looking at, long-term outcomes and saying, if someone's eventually going to go on Medicare, well, is there a cost benefit to us? And some people are saying no. So in my clinics, I would say, I can get coverage for just an obesity indication, and that's with a lot of help, probably 70% of cases. But 30% of cases, we have to find a new solution. And these are some medicines that we can use, but there are other older school medicines that we use in obesity as well.
If I could add to that, a couple questions came up about sort of cost, which is obviously a real issue. There's an MIT economist that estimated if you put everybody with obesity on a GLP-1 receptor agonist, it'd be about $1 trillion was the estimate, and the savings they estimated was about 200 billion. Obviously, it depends a lot on assumptions there, but it is a real expense. The thing I see clinically, though, which sounds kind of goofy, but I think it's true, is that people report that their food costs go down because their food intake goes down. So people say they're eating one meal a day less and they're saving $20 a day on food. That does add up. Some of the alcohol and tobacco, these other things are improved with these drugs for whatever reason. The dopamine reward pathways, whatever, are being improved. And so the cost-effective analyses are tricky, but I think worth considering further. Certainly the cost of the medications will probably come down over time as well with as more and more become available. The other point I think Tatiana was asking in the chat was about stopping the medication. So the Surmount-4 study was in JAMA in January by Lou Aroni, and it was tirzepatide-treated patients who randomized to either continue tirzepatide or go to placebo. So it was a randomized withdrawal. And perhaps predictably, the body weight comes back pretty quickly if you stop the medication. So it is incumbent on us to either pursue long-term therapy or get diet, exercise, other things in such a way that you can sustain the weight loss, because transient weight loss isn't going to help anybody long-term, at least. The Eli Lilly and others are working on maintenance drugs as well. So a lot of these companies have skeletal muscle agents that they're working on to sustain weight loss. And then there's drugs like orforglipron and retatrutide, which are in the pipeline that we're working on in this context as well to sustain the weight loss. There was a question about pediatrics and adolescents, and there are ongoing efforts in that space. Can't say much more about that.
And in terms of chronic therapy, as far as we understand, and it's happened over and over in any kind of even with the old phentermine topiramate studies, but certainly in the extension trials for SEMA and more recently tirzepatide, we know when we stop these medicines, people regain weight because obesity is a chronic disease. It needs chronic management. There are ways to improve weight maintenance, and so diet and exercise are part of that, but whenever we start these medicines, patients should anticipate that they will be on some form of weight loss medicine for the remainder of their life. This will hopefully, this should get cheaper in time. And I think we're at a point in time where these are expensive, but in time, these medicines should get cheaper. And hopefully that it'll be easier to do this, but because we know that weight is, a disease process of really satiety, they should expect to be on these medicines forever.
Just along those lines as well, a bunch of questions about sleep docs prescribing these things, and I think it's great to think about broadening the availability and accessibility of the medications. I will say the trial we did was sponsored by Eli Lilly, and it's very different from an NIH funded thing. Most of the research I do is NIH, and the budgets are relatively modest. With a $1 trillion company, they can do things in a different way that we ever could in a purely academic setting. So they had monthly visits with registered dietitians. It was very hands-on in terms of that. You may have noticed the control group having big improvements in Surmount-OSA, and the question is that a placebo effect? Probably not. It's probably active treatment from the registered dietitian, these visits and whatnot. Similarly, there's a Hawthorne effect of being in these studies so that people know that Big Brother's watching, things tend to improve over time. But if we just start giving the medications in a sleep clinic without the other supportive infrastructure for diet, exercise, education, whatnot, that may not be recapitulating what was done in the trial.
100% agree. Again, I think that you need multiple hands. Nutritionists are important. Mental health experts are important. There's a lot of different pieces. So you definitely need, and these patients need regular follow-up, which, as Brandon noted, it's getting harder and harder in sleep clinics as we get very busy, and there just aren't enough. I'm sorry, in weight management clinics where we get very busy, and there just aren't enough slots to see all these patients.
Brent, there's a question about thoughts on using GLP-1 and patients with obesity OSA and on HRT, TRT.
Hormone replacement, you mean like estradiol? So are we saying testosterone replacement therapy? Is that what we're...
Both. So
okay.
Ron, maybe you can specify.
Thyroid?
Yeah, is it thyroid? Is it testo? Is it estradiol? That can be a lot of things. So I'll how about I answer all of them? It's fine. You can absolutely start it. So totally fine to start patients on testosterone replacement therapy. The thing that I want to mention, right, is that patients with obesity often develop OSA, and they have often two reasons to have maybe a little bit of hypogonadism. One, having extra fat cells, you have more aromatization of testosterone. So patients tend to develop maybe a little bit of hypogonadism with that. And OSA is thought to have some central effects on the testosterone pathway. So you can have hypogonadism with because of those two disease processes. So most often, I would say recheck the testo as patients improve to make sure that they still need the testo in the future, right? Because as their weight improves and as their apnea improves, you can see the testo pop up.
Yeah, just to add to that, I think Perez had a paper about 20 years ago looking at gonadotropics being suppressed with sleep apnea, and so potentially a protective mechanism in some ways to suppress the testosterone, but it does improve therapeutically. The other point to make, which maybe Brian can comment on, is pancreatitis. It's something we worry about a lot with these medications. There are only 1 or 2 cases in Surmount-OSA, and I'm a critical care doc as well, so I did a deep dive on those 2 cases, and both were fairly trivial in terms of mild cases. There's probably some ascertainment bias because people come in with nausea, vomiting, abdominal pain. We check in amylase and lipase just there. It's the end of diagnosing it probably more. But there is some link, Brian, I think, with these hormone replacements and testosterone, estrogen with pancreatitis. I don't know if there's any interaction there that concerns you at all in terms of GLP-1 receptor agonists and sex steroid.
Sure. So first of all, estrogen certainly increase triglycerides, and that's your kind of mechanism for pancreatitis with estrogens. GLP, some people say the jury's out. I'm cautious. I think that it's real. Okay, I think it's very rare that you can have a GLP related pancreatitis, and frankly, I see more gallbladder disease because of GLP than pancreatitis. But if someone has a history of pancreatitis, I say that these medicines are bad choices for you. I'm also terribly neurotic and have everyone I ask about alcohol use, if they're drinking, above, 5 drinks per week in women or 7 drinks a week per men, I usually still target less than 5 per week on average. Then I say, you got to cut down and you have to be honest with me. So I have patients tell me in a couple weeks, were you able to cut down? The reason I don't chase them as much is because of the data that patients often have a decrease in alcohol use once starting these medicines. So once we push them down to a reasonable amount, if they can get down to a reasonable amount of alcohol use, and I'm not asking people to be monks, right? They can still drink sometimes. But if they can reduce their alcohol use to a reasonable amount, they often are able to keep it down with the medicine. There are some people that they're drinking 20 or 30 drinks a week. I will not start medicine on that. That's not a safe choice. They really need to cut down on the alcohol use first. The other piece of that is that alcohol affects weight. It's empty calories. And people have impaired executive function, so they tend to eat, a worse diet. When you drink, you tend to make poorer choices as far as diet. So alcohol reduction is a big piece of this, but like we said, there's a lot of pieces. But I tend to say cut down the alcohol, and then we start alcohol. We can start medicine. I think it's real, but I think it's rare. And and I do warn all my patients about it. And I say, if you have terrible abdominal pain, just present to the ER. So if they have gallbladder, and that should cover whether they have gallbladder disease or pancreatitis.
So Brian, you just ruined my weekend, I think, with the alcohol comments.
Sorry about that.
I will say neither of the cases in Surmount-OSA, there are 2 cases out of almost 500 patients, and neither were biliary, as best we could tell, at least reduced biliary disease. But I think the reduction in alcohol and tobacco intake are real. I see that clinically all the time. Part of the cost-effective analysis, is to say people reduce their food intake, but they also reduce their alcohol and tobacco consumption. So net for an individual, even paying out of pocket, there, you have to factor that in. Is prior cholecystectomy decreased pancreatitis risk when considered starting GLP-1 agonists? So I don't think there are a lot of data on that. And as I said, the 2 cases we saw were not biliary. There were some data from Nutrisystem, I think, that oral fat intake is important for gallbladder release. So cholecystokinin is released with oral fat intake, but we didn't see biliary disease, at least in the 2 cases, as I mentioned.
Yeah, I think the pancreatitis is still being debated. I just tend to be conservative about it. So,
even in the Surmount-2 study, it was in the
Yeah.
Lancet a couple of years ago by Garvey, which people with diabetes. There's only 1 or 2 cases of pancreatitis, even in that context. So I think it's rare, but real.
Yeah. So reading. Yeah. So and regarding lifestyle, yes. So and I hate the word lifestyle. And I know Anya pretty well. I think she also would get frustrated. She doesn't love the term lifestyle, but the idea is correct, or what we conventionally think of as lifestyle. But I'd say healthful choices are incredibly important, right? And that's, in all these studies have great support with, dietary control and exercise and all this. What ends up happening on GLPs, right, is that people have more satiety. So and when you have a real discussion about what is a healthful diet and what they should be choosing, you at least have a better chance of adhering to that, because things like having a cake are not, people worry they're going to feel nauseous because it overstimulates that satiety. But but talking about healthful food options, but the difference in goal nowadays is not starvation, right? Crash diets don't work. It's eating a healthful diet, having regular exercise of at least 150 minutes per week. When we look at studies, to have any really significant weight loss, it's really closer to 300 minutes a week, which is not really sustainable for most people, right? That's what, 5 hours a week, every single week? Ooh, that's a lot. But those are absolutely important things. What is propagating all of this is probably our foods. Well, I'll argue. We don't know for sure. I think our food supply is changing. I think our sleep habits are getting worse. We're all sleeping less. And we know that sleep deprivation has effects on ghrelin and leptin. There's a great study from Ken Wright from U Colorado, where he put people in indirect calorimeters looking at hormone levels with sleep deprivation. So it's really fascinating stuff. And we're becoming more sedentary because because everything, you have to drive everywhere, and more of our life is on the computer. So there are definitely pieces, but lifestyle alone doesn't cause enough weight loss for most of our patients, right? 2 to 3%. In some studies, you'll say maybe as much as 7% at max. And most of these patients need closer to a 20% or more weight loss to achieve a healthy or a better place from a weight standpoint, and have really significant effects. 5% or more is metabolically important, right? 10% or more has effects on apnea. ACE says 7 to 11. I say about 10%. So I think that the answer is yes, all those things matter. But keep in mind that medicine probably pushes the needle, might be the first thing to push the needle towards that.
Just to respond to, I think Dr. Schmickel, my colleague, has comments in the chat, which I generally agree with, but just the analogy he's drawing is, we withhold statins on people because we haven't done diet and exercise adequately.
Yeah.
I think it's a good analogy, but I guess what I would counter with is when the FAASM study and the West of Scotland study and the other statin studies were done, they weren't in the context of intense diet and exercise and all this. In contrast, the way we did Surmount-OSA was with diet, exercise, the whole support staff. So it wasn't just giving people medicine. It was in the context of a more comprehensive program addressing diet, exercise, and sleep as 3 pillars of health. So the analogy is okay. It doesn't mean withholding statins from people, but it's not how the drug was done. I guess we'll need real world studies to see if you just give people tirzepatide in the context of a sleep clinic without registered dietitians, et cetera, do you get the same results? And the answer is I don't know.
Great. Well, I think this has been a lot of fun. Any other questions from the audience? Well, thank you all for coming. Yeah, this should be recorded and posted in the coming week, okay? And if you think of any other questions, feel free to reach out.
Well, thanks for having me.
Thanks, Brent.
Yeah.
Thanks, Brent. Good job.
Thanks.
Thank you.